Well, thanks, Bob, and it's really nice to be here at this very warm and important learning community conference. It's also really nice for me to be reconnecting with the VA. I think a lot of people don't know it, but my entire career in mental health began back in, I hate to say this date, 1965, when I was a summer trainee in the VA program at Hines VA Hospital in Chicago. Somebody from there, right? I still remember the first day of that summer as if it was yesterday because I was so totally and absolutely traumatized. I'd never worked with a client in my life before, and the very first client that was assigned to me was the most difficult client they'd had on the unit for years. I think it's kind of a rites of passage for training programs to give the very green student their worst client. I hope you don't do that with your students because it was bad. First client given to me, unfortunately, was a man named Mr. Stanwyck, who had many years before put a revolver in his mouth and pulled the trigger, and he had no face and severe organic brain damage and had to breathe through a tracheotomy tube. Needless to say, I had absolutely no idea what to do with him, and it really became apparent to me soon that he was never going to show up at my office if I waited for him there. So I kid you not, I think I did my very first assertive outreach at Hines VA. Ended up going out and spending many afternoons that summer doing what I called hallway therapy with Mr. Stanwyck, walking side by side with him wherever I could find him and trying to give him a little bit of support. What I remember most about that summer was that I had terrific supervisors who really encouraged and supported me to do things differently when the status quo wasn't working. And that was a really important experience that the VA left with me. And I think this conference really has the same theme of learning to do innovative approaches when the status quo isn't working with clients. And that's what you're about, to try to help people with severe mental illnesses have a better quality of life. I really applaud you for being here and being part of what I see as probably the movers and shakers in the VA system. Every organization that I've ever worked with has a group of people who really want to do good stuff and want to change and innovate. And for every one of those people, the organization's hired 15 people whose job description says, don't let anybody change anything here. And you're in that first category, and that's terrific because I think you really will be helping your clients by learning these new approaches. I also want to thank Bob Rosenheck and Mike Neal for inviting me to speak. Bob and Mike are two of my real heroes in this field. They've been national leaders in both doing research and training and dissemination for many years. I think unlike perhaps most researchers, they're not content to just let their research stay in journals, but actually make sure that it gets innovated through dissemination efforts like this. I'm actually supposed to give a serious talk tonight, I guess, educational, which is hard to do. My father many years ago gave me some tips on public speaking, and I think they're kind of appropriate tonight. He said, if you want to be seen, Marianne, stand up. If you want to be heard, speak up. If you want to be appreciated, sit down. Bye. I think after a full day of talks, and my brain is, my blood is all in my stomach and not my brain, this will be a challenge. I'm supposed to be talking about assertive community treatment works, and believe me, I don't intend to recite a long list of research studies. I found out from my teaching at Wisconsin that talking about research to clinicians after a big meal is an excellent sleeping pill. I think I want to market it to a pharmaceutical company sometime, make a lot of money. So I first want to start off by describing how the ACT team or PAC team did begin back in the late 60s. And at the risk of sounding non-scholarly, I want to tell you the true story of what happened, not what we write about in journals. I think if we ever told what really happens when new programs are innovated, it would never be published. but I think this kind of information is much more helpful to clinicians because I think you'll probably be able to identify very well with the problems that we were trying to solve. Then I want to talk about some of the treatment guidelines and clinical implementation of the PACT model as it now exists in Madison 30 years later with quite a bit of fine-tuning. My purpose is really not to tell you what you should be doing, but to just give an example of some of the principles that people have been talking about today kind of in action in an actual treatment model to stimulate your thinking about things that might work or not work in your settings. And then I'll probably just give a very brief summary of research findings, but nothing extensive. Okay, my slides are on. You see I'm using slides and not PowerPoint. This is low technique because I work in a school of social work, not a medical school. You see, I only have two colors, white on blue. Nothing fancy. That's right. In the late 1960s, a number of us were working on an inpatient research unit of a state hospital in Madison, Wisconsin. And following the institutionalization at that time in Wisconsin, the traditional care system was very similar to what it was around the rest of the country, namely what you see on this slide. Namely, patients are treated in the hospital for a relatively short period of time to help them resolve their acute episodes, but then are discharged to a fairly limited aftercare system. I think this system still continues to be the status quo in many communities in the U.S. today. We were working on a research unit for people with very chronic schizophrenia, people that other units had not been able to get out of the hospital, and our job was really try to develop and evaluate innovative approaches to help these clients leave the hospital and stay in the community. And in fact, we were indeed able to help many of them leave and go back to the community. In this unit, though, we did our work in phases, and after each new program that we would evaluate, we would discharge clients ready to go. And then the entire staff would get together for a planning party, and a party to try to brainstorm about what we as a staff should do next. What kind of a treatment model should we try? And this is a very egalitarian unit, so everybody in the unit came to the party, professionals, paraprofessionals, the ward clerk, and so forth. Well, at the party in the summer of 1970, it turned out that hardly anybody came. Most normal people would not be upset if not many people came to a party. You'd think there's more food to eat, more, beverages to drink, and so forth. But I'm sure all of you know mental health professionals are not normal people. So we had to put our chairs in a circle and sit there all night and process why nobody came to this party. This is a true story. You can see why no journal will publish it. And as the staff talked, and Arnie Marks, the psychiatrist, the unit chief, and I was the associate director of the unit, as the staff talked, it became apparent that morale was very low on the unit, and Arnie and I tried to figure out what's going on with the morale. And the staff said to us, well, what we're doing on our clients isn't doing any good. We're not doing our clients any good. We work really hard with our clients work really hard, they make progress, they get better, we discharge them, we link them to this aftercare service out there, and they're all coming back. And it was true. Sometimes a matter of days, sometimes a matter of weeks, all the clients would eventually rotate back, often in a very psychotic state. If they didn't come back, we got word they were living very poor quality of lives in the community. So as the party progressed, the staff are saying, we're just wasting our time. We're wasting our clients' time. Our clients aren't getting what they need out there in the community. Finally, and these are the 60s in Madison, which is the Miller Brewing headquarters of the world, I guess. Alcohol is being consumed. Somebody said, we just don't want to, we're not going to do another one of these inpatient programs. We're not, this is not worthwhile. Sometimes when you give staff power, they take it, it's bad. So we asked the staff, well, what do you think would help? What would do better if we don't do these? And somebody said, well, you know, when Barb Lantz, the social worker on the community, on our treatment unit, is able to go out to the community when we discharge a client and help that person, they don't seem to come back. And Barb was a very innovative social worker who didn't have time to work with everybody on the unit. But some clients that we discharged, she would go out and we said, well, what is Barb doing? Well, she would help them move into an apartment. She would help them to learn how to use the local laundromat by going with them to do their laundry. She would ride the bus with them week after week to the mental health center so they would learn how to do that. She would teach them how to shop in the local grocery store. She would even get the landlady or landlord her home phone number in case a crisis came up, and she would go out. So Barb is essentially giving the clients that she discharged side-by-side support, going out to them and helping them with whatever they needed. And as the party went on, people said, you know what, Barb does make sense, because, you know, the community is a place where people with severe mental illnesses need help, not the hospital. People even get too dependent on the hospital. This is where their life is stressful. Well, the party, more and more drinking was taking place, and somebody said finally, you know, why don't we all go out in the community and help clients? And why don't we all be like Barb, and then we can keep all our clients out there. Morale was starting to get a lot higher, and the staff was getting much more excited. Somebody said, you know, hell, maybe we don't need this hospital anyhow. And Sister said, well, if we give our patients enough support in the community, maybe they won't have to come to the hospital anyhow. Somebody said, let's shut this damn ward down anyhow. Let's close this building down. Well, this party ended, morale extremely high. And Arnie Marks and I got back to the unit the next day, and Arnie said to me, we had terrible headaches, don't know why. Arnie said to me, Marianne, did we tell the staff we were actually going to do that? I said, I think so, Arnie. And that's what we did. And that is exactly how this idea came about. And the very next day, actually, we got together with Len Stein, who was director of research of the hospital at that time, and Arnie and Len and I and some of the other staff started trying to brainstorm and conceptualize what a new model of community care would be. When I tell my students this story about how PACT began, they always think the moral is that staff should have more parties. But I think the real moral of this story is that clinicians and researchers really need to work together, because I think that clinicians, like many of you are, who've worked with clients for many years and know them very well, have just great ideas about clients and what they need, and that we were, the only brains we had was to listen to our staff in terms of what they were saying. In conceptualizing then this new model of care, we tried to take a closer look at what was the problem with the community care system at the time that you see up here. And the limitations that we noticed are these, and I'm going to use present tense now because unfortunately these limitations still exist in many, many places. First, given the ongoing severity of our clients' illnesses and their continued high vulnerability to stress, it seemed to us that when clients got to the community, they didn't get enough support or treatment. We knew our clients weren't cured, and they weren't getting intensive enough treatment, and they weren't getting comprehensive treatment. At the time, many clients were just getting medications and outpatient therapy. And now I think we all realize that clients need a lot more help in the community if they're going to survive. They need help with meeting their housing needs, what they're going to do during the day to have meaningful activities. They need help in making friends with all kinds of daily living tasks. So treatment in the community need to be much more comprehensive than it was then. Secondly, over time, a number of communities did start developing different services to meet clients' needs, but many times these services were not and are not still individualized, and they're often not what people want or need. To get support, many clients, for instance, may have to go to special living arrangements to live. They may have to go into day treatment centers to have something to do during the day. But clients are human beings like the rest of us, and many of them want other things. Many clients want to live where they want to live. They want to do meaningful work for real pay. They want to eat the food they want to eat and so forth. So many times community care systems are not individualized. And I think many times when our clients drop out of services, they're really voting with their feet. This isn't something that will meet their desires or goals. Thirdly, we saw many community programs were requiring clients to come into the office or program to get treatment. And if a client didn't show up, the case manager will often close the case and say this client isn't motivated. Well, the reality is that along with sometimes voting with their feet about not finding a service useful, most clients, I think, drop out of treatment because of the very symptoms of their illness. Disorganized thinking, negative symptoms of just total lack of energy, poor social skills, sometimes paranoid thinking, sometimes lack of confidence in taking a bus, no money. These are the reasons why clients don't come into treatment. And we can't expect them to, and as a result, clients will drop out, relapse, and often come back to the hospital. A third problem is that many communities have developed care systems with a number of different agencies to meet different clients' needs. But often this ends up being a very complex and fragmented system or a non-system. Often under different roofs, people get services for housing, for crisis support, for medication, for socialization. And it becomes really impossible for providers to integrate care, and certainly impossible for people with severe mental illnesses to negotiate these complex systems. I often think that the more disabled a group is, like the elderly and so forth, the more complex the system is that we develop to serve them, and this won't work. So to kind of summarize, I think the common, whoops, not sure if I'm not pushing hard enough. There's a little delay here. Okay, to summarize then, I think the problems, the challenges that we face in delivering community care, and I think that all of you face, are first that we need to provide comprehensive services that address virtually all areas of a client's life, but we want to make these services individualized so they help clients move toward their goals. But then if we need multiple services, how in the world do we organize and deliver these services so they actually get to our clients in a timely manner, because our clients often can't get to them? So the field since the 1970s has been trying to solve these problems, and I think the solutions that have been tried kind of lie on a continuum. Unfortunately, the solution at the top is the one that I think is most frequently used in the U.S., and it's also the one that has the least research support. That involves kind of a broker or standard case management system. In other words, what communities do is create an array of services to meet different aspects of a client's life, and then they insert still another fragment in the service system, a broker case manager, whose job is to try to coordinate the rest of the system by advocating for the client, doing treatment planning, linking, and the monitoring of the system. And this has taken place in many communities, and there really isn't much research support for this solution. It's not quite clear why this doesn't work, but I think that some of the limitations of this system are listed on this slide. And some of you may have served in these broker case management roles, and despite, I think, very heroic efforts on the part of broker case managers, might have encountered these problems. First, the case manager often has little formal power over other providers in the system. So you may want to refer somebody to a certain kind of a work situation or housing situation, but that agency says, well, I'm sorry, we have a long waiting list, or your client doesn't meet the criteria that we have. Most criteria usually say the client has to be better before they'll take them, so forth. You know that story. And secondly, the case manager, or let me say the community, many of the services that a client needs don't exist in that system. So it's hard for a broker case manager to link a client, obviously, with something that doesn't exist. And thirdly, the needs of people with severe mental illnesses often change very rapidly. And the case manager isn't available 24 hours a day, 7 days a week, so he or she often can't respond to these crises. And often it's really a slow process of trying to get this whole system of different people and different agencies together to try to get them to revise and update the treatment plan. If we go back to other solutions, some communities have used the middle solution, which is to really expand the broker case management's role somewhat. So here the case manager is expected to not only coordinate the care system, but also provide some direct services to the client themselves. And then at the bottom of the diagram is an approach that's quite different from the others, which I'm calling PACT or ACT, Programs of Assertive Community Treatment, or MHICM, is that the right acronym, MHICM? The VA modification of this. This model is quite different because rather than trying to use a case manager to coordinate a fragmented system, this model really tries to avoid the creation of a whole fragmented system by having a well-staffed multidisciplinary team itself provide clients with almost all services. So you're really trying to avoid the fragmented system. In terms of exactly where MHICMs, I still can't get that right, might lie in this continuum, the VA approach is a modification of assertive community treatment, and it's very close to the bottom where PACT is, but maybe a little bit more in the middle, where I think because of the different staffing patterns of your teams having a lower number of staff typically, the staff are still having to do some referral out, but do a lot of the work themselves, if I understand this correctly. Anyhow, there's a great deal of support for the effectiveness of the Bottom Approach Act and certainly the VA modification of it. PACT was developed and by a large number of collaborators, and these evolved over time, so this work is the responsibility of many people, some of whom are listed on this slide, and we've also enjoyed funding from the NIMH Wisconsin and the University of Wisconsin grad school. Just to give a definition of assertive community treatment, it's really a community-based integrated team approach to assisting consumers in living a satisfying, hopeful, and contributing life in the community. I'd like to describe the PACT model to you now in a little bit of detail in terms of how it exists now in Madison's. We made some changes. Our original work, we were working with clients very similar, I think, to a number of your clients, many times middle-aged people who had spent a fair amount of time in institutions and were coming out of the hospital, and we worked with them then. Our current work is with really quite young adults, ages 18 to 30, who really haven't been in the hospital very much, and we're really trying to use total community treatment to try to reduce a lifestyle in a sense of beginning dependency and not functioning too well, and so forth. I think you'll see many, many similarities in what I'm going to describe and some differences, and I'm really presenting this example to stimulate your own thinking about things that you think might work or not work, or other ideas that might be triggered in your own work. I apologize that some of this is going to be redundant with some things we heard this afternoon. At the heart of the PACT model is what's called a core services team. This is a community-based multidisciplinary team which serves as a fixed point of responsibility for a defined group of clients. Our team has a very high staff-to-client ratio, as your teams do, about 1 to 10. In Madison now we have a team of about 12 staff, probably working with 120 to 140 patients, actually changed since this slide was made. The team works out of a storefront office in the center of community, and our team actually does provide coverage 7 days a week, 24 hours a day. We have an AM shift and an evening shift every day, and then the staff on the same team carry a beeper page system during the night hours so they can respond to the clients in crises. I think three things are really important about how ACT teams or MHICM teams operate. The first is, again, that the team itself assists clients in almost all biopsychosocial service domains rather than trying to link the clients to an array of other providers as more traditional case management does. And in fact, we have a high staff-to-client ratio, so the team itself can do work in helping clients with housing, work rehabilitation, medications, crisis intervention, and so forth. I think the real advantages of this one team does all approach is that it really avoids the complex fragmented system that I talked about before. Having the same team work with clients in all the areas of treatment, rehabilitation, and support really allows what I call the complex interaction of symptoms and functioning to be addressed. I think more and more we're learning that certain problems caused by the illness, like in schizophrenia, trouble with concentration sometimes, memory, information processing, so forth. It's these kinds of symptoms that often keep clients from being able to work. For instance, if a client has a lot of trouble with attention or concentration, they're not going to be able to work in a job that demands that. But there are many other kinds of jobs they will be able to work in. So if you have the same staff members on the same team who know the client's symptoms very well and the work rehabilitation staff on the same team, they can communicate very easily around what kind of work situation might be best for this client. Or if you have a person who knows substance problems on the team, and if a client's a substance user, he or she will be very direct about telling the team when they're helping the person find housing, do not put this person in the central city where drugs are very common. PAC now uses this wonderfully scientific intervention for substance use we call move to the suburbs, and literally by helping clients live away from the substance area of the community, it seems to help a lot. Also, having the same team help clients in all areas really provides a continuity of caregiver as well as a continuity of care. People with severe mental illness, as you know, have a lot of trouble with interpersonal skills, and therefore these clients only have to relate to one set of providers and not a whole bunch of the different agencies. And finally, I think the thing that family members like best about ACT programs is that this team is really a place where the buck stops. So if anything is going wrong, if they're unhappy about anything, they can call this team, and you have to deal with the client and that problem. You can't say, oh, I'm sorry, we're not the agency that handles that, blah, blah, blah. And I think that's important for both consumers and family members. The second key characteristic is obviously that the team is mobile. Team members use assertive outreach to provide most services in vivo on the client's turf. Each morning the staff meet in an office and get their daily assignments, as Mike was talking about, and then really spend the day and evening fanning out into the community, actively working with clients. In our studies, we found that 78% of the time that staff work with clients is out on their turf, not ours. This assertive outreach obviously minimizes dropout, but it also enables clients to get support where they need it, where they want to be, where they're carrying out their life, if you will, so that they don't have to come into a facility to get support. Third critical aspect of how the core team operates is that services are highly individualized. In fact, we really don't have a set of programs to which we refer clients, but we actually start with each client almost anew, and with that client do a careful assessment like Mike talked about, and then really try to develop a highly individualized treatment plan with the client that helps meet their goals. And I think the VA, the way it's structured, system has available more things like day treatment and maybe